Okay, so welcome back to this series on Introduction to ECG or reading ECGs. We're going to continue now in our sequence of how to read the ECG. So far we've spoken about rate, rhythm, and axis. And now we're going to learn how to read the ECG as it regards to the waves, segments, and intervals. Good. So there are many approaches to reading the ECG, but I would recommend going in sequence from left to right. So analysis of the P wave, then PR segment and PR interval, the QRS complex, the ST segment, the T wave, and then the QT interval. Now, this video and the videos that follow are meant to be an introduction to concepts and will basically give you an idea of what's normal, but the information given won't be absolutely comprehensive. So we'll have to go into greater detail in future videos when we speak about, for example, chamber enlargement, ischemia, myocardial ischemia, and other concepts, right? So it's just an introduction, okay, and an approach. So firstly, with the P wave, all right, what are we looking for? So we're analyzing the P wave for height and width. All right. So when we speak a bit more about chamber enlargement, we'll get into what's abnormal for P wave height and P wave width, right? But for now, all right, we're going to look at the end of this video or the next few videos, we're going to look at some ECGs so that we can just get a vague idea of what's normal, all right? But it's just for you to know that we have to look at the P wave height and width, and we look in two leads, V1 and lead 2, which is pretty easy, right? So 1 and 2. So in summary, when analyzing the ECG, when we want to find out information about atrial impulses, because that's what basically the P wave represents, we look in V1 and lead 2 because those leads have the best view of the atrium on the standard 12 lead ECG. Okay, so next we will look at the PR segment, and there's not much to say about it for dialogue about the introduction to ECG. What I will say is the main thing we look for is PR segment depression, which is seen in pericarditis. Okay, mild downsloping of the PR segment can be normal and by itself is not diagnostic of anything, right? So the PR segment, it's useful, but it doesn't give us a whole lot of information, all right? But in sequence, going in this order, right, we should still take a look at the PR segment, right? So the next thing, which is even more important, is the PR interval, right? So the PR interval, we have to analyze its width. All right, so let's draw a diagram here. So as we mentioned earlier, ECGs are vector analysis diagrams, and the values are on the y-axis millivolts and on the x-axis time. Okay, so when we analyze the width of the PR segment, we are basically analyzing time. So what does this time represent? So this time represents the time taken for atrial depolarization as well as the delay before the start of ventricular depolarization, right? So it's essentially the time taken from impulse formation way up in the sinoatrial node or wherever else in the atrium the impulse is originating, because impulses can originate from ectopic sites. So it is the time taken from the beginning of atrial impulse generation, right? Its entire period of time to propagate through the atrium, as well as the time taken for the delay that occurs normally inside the atrioventricular node, right? And the total time that this process takes before activating the ventricles. So that was a little bit wordy. Let me just say it again. So the PR interval represents the time taken for atrial depolarization as well as the refractory period inside the AV node before ventricular activation. Okay, and this is important because some conditions cause disease of the atrioventricular node, and disease of the AV node will result in either delayed ventricular depolarization or even sometimes absence of ventricular depolarization. So the impulse coming from the atrium won't make it into the ventricles, right? So the PR interval width, right, should be, let's see, where can I draw this? The PR interval width should be between 3 to 5 small boxes, which is 0.12 to 0.2 seconds. And that's it for analysis of the PR. So the next area of the ECG that we would analyze is the QRS complex. So this approach is one way that we can analyze the QRS complex, right? Q R S plus, where Q stands for Q waves, right? R stands for R wave progression. S stands for size, which includes the width as well as the height. And plus stands for certain conditions or certain abnormalities that we'll look for later on when we go into detail about types of blocks. So for example, fascicular blocks, bundle branch blocks, that type of thing, right? Okay, so let's break this down. So Q waves. So what are these? Well, as we've mentioned before, Q waves are the first negative deflection of a QRS complex, right? So for example, this would be a Q wave. So how are Q waves formed? Well, if you have a lead, for example, lead 1, a Q wave would be formed if the initial impulse is going away from the lead. Okay, so this impulse will give a negative deflection. All right, so this complex could be formed in multiple ways. It could be that the initial vector goes away from lead 1 and then goes towards lead 1. So there can be a change in the direction of the vector, right? Or it could be that the vector goes towards lead 1 but at an angle, and that would still result in a wave like this, which is predominantly positive but has a negative component. But the summary of the concept that I want to communicate is that a Q wave represents that the initial part of the vector that we're looking at in a particular lead goes away from the lead, and then if there is an R wave that follows, that R wave suggests that the vector is coming towards the lead. Okay, because remember, the ECG, right, or more specifically the QRS complex, is a vector diagram, right? So at different points in the depolarization, the electrical impulse may go away from the lead and then towards the lead based on the normal anatomy and physiology of the heart, or pathological processes, and also the placement of the lead. So then, the next logical question would be, are Q waves normal? Are they abnormal? Or, are they sometimes normal? Well, now we'd have to get a little bit into, we'd need to go into some further detail about the normal depolarization of the heart. So let's draw another diagram. All right. So let's speak a little bit about the sequence of depolarization in the ventricles, right? So what this diagram is to illustrate really is that we have an AV node. We have the AV node in the apex, which then goes into the His bundle, then into Purkinje fibers, which are inside of the right and left ventricle. And the initial conducting fibers are located in the ventricular septum. The left ventricle is a larger chamber and a larger mass of myocardial tissue than the right ventricle. Okay? Now, normal conduction proceeds, as we would have mentioned before, first to the AV node, where there's a normal delay, right? Then to the His bundle, right? And the His bundle, after the His bundle, there is initially depolarization of the left side of the ventricular septum first. So we have left septum, and then it depolarizes like this. All right, so left septum, then right septum, then left plus right ventricles. So then the impulses just spread around like that. Okay, so that's a lot of information. AV node, His bundle, left septum to right septum, then both of the ventricles. So what does this mean? Well, essentially, if we're using a lead such as lead 1, where the positive electrode is towards the left, right? And remember what we said. If impulses go towards an electrode, towards a positive electrode, we get a positive wave. And if impulses go away from the positive electrode, we get a negative wave. So what we're saying is, if we're looking at a lead that's towards the left side, during septal depolarization, which is right here, you can see that septal depolarization will be going away from the positive electrode that is located on the left side of the body. So that would result in a negative deflection. Now, the septal tissue is small in comparison to the entire mass of cardiac tissue that is the right and left ventricles. So it will be a small deflection in comparison to the depolarization of the rest of the heart. Now, when the right and left ventricles depolarize, the right ventricular depolarization will be heading towards the right, and the left ventricular depolarization will be heading towards the left. But because the left ventricle is a much larger mass of tissue, when both of these vectors are summated and you get an average vector, it will be going more towards the left. And that's why, for example, if you're looking in lead 1, right, lead 1 right here, which is on the left hand side, the vector will be going towards lead 1, so you'll get a nice R wave like that. Okay, so just to repeat, during septal depolarization, which happens first, the impulse will be going from left to right in the septum, resulting in the impulse going away from the leads, the positive leads on the left hand side. So you'll get a small Q wave, right? And then when you have ventricular depolarization, because even though some of the impulses are going towards the right, because the left ventricle is a much larger tissue, muscular chamber, right? The mean electrical vector, when the right ventricular vectors and the left ventricular vectors are put together, will result in a mean vector going towards the left, which is in the direction of the positive electrode in lead 1. So that will result in a large positive R wave. So in summary, the answer to the first question, which is, or to one of the questions, I don't remember the order that I said it, but the answer to the question as to whether or not Q waves are always abnormal is that no. It is normal, or it can be normal, to see small Q waves in the lateral leads, right? And even often the inferior leads, and these are called septal Q waves, right? So they should be small in comparison to the rest of the QRS complex, if they are present. So that now begs the question, what do I mean by small? So they should be less than 25% of the height of the QRS complex, height of the QRS complex, and they should be less than 1 millimeter or one small box wide. So for example, this would be a small septal Q wave, because compared to this R wave, right, or rather the entire vertical vector, it's really tiny, right? It's less than 25% of that vertical vector. And there's no small boxes here, but for example, if I were to draw some small boxes for illustration's sake, like that, you can see that it would be small because it's less than one small box. Okay, all right, moving on.